My name is Al-Ola Abdallah. I'm one of the myeloma physician. My work as a plasma cell disorder program director at University of Kansas, and also as a, I'm one of the directors of the U.S. Merck. We had many presentations, and mainly the highlights I want to talk about is several important ones. One of them was the GLAMM study, which is Global Access to Multiple Myeloma Medications. We have two parts of that, and we thought it was very interesting to see issues about access to many anti-myeloma drugs. The first part actually focused on access to the newer treatments, the BCMA-directed therapy, as well called two parts, which is CAR T-cell, two of the drugs that got approved, the cilta-cel and the ide-cel, and the teclistamab. What we have actually done is that we reach many oncologists all over the world, except the United States, 33 countries that have about 95 response from oncologists, in order to discuss if they have these drugs available. Shockingly, the results were showing that there was a lot of limited access, even in countries that were known of high income. And I think the problem about that is either the treatments was relatively new or because of the financial burden. The results unfortunately show that only 9% have available or access that was considered available, these CAR T cells to them. The bispecific with teclistamab showed a little bit better results at 23%, still low, but it was still better than the CAR T cell, although the teclistamab was approved after the CAR T cell. Again, I think we thought that this is actually all related to the financial burden, maybe because of local regulatory not approving it yet, because there's no major phase 3 trials that have been available at that time. But we would like to work with these agencies as a group, in order to kind of overcome these, these issues, to get the treatments with the CAR T cell and the bispecific available for them in the near future. The second part of the GLAMM study, which is part 2, also actually discussed about anti-myeloma drugs, but it was actually discussing about the older treatments, including the 3 drugs, the proteasome inhibitors, like Velcade or pertuzumab and carfilzomib and ixazomib, and also drugs like immune modulatory drugs, thalidomide, Revlimid, and pomalidomide, and CD38 monoclonal antibody like daratumumab, isatuximab, and other anti-myeloma drugs that are approved by the U.S. We also contacted these same population of physicians. 95 of them who responded, 17% of them were known that they were also managing only plasma cell disorder, while 50% of them were known that they were actually also in university-based hospitals. The good thing about that we saw a really great results about availability of these drugs. However, there was surprisingly that one of the classes, which is the CD38 monoclonal antibody like daratumumab, isatuximab, was barely present in 70% of the cases. When I say 70%, it's still low because this class is very important and critical. We do look at it as an issue because this can actually improve the survival of myeloma, especially worldwide, and it's very easy to tolerate for a lot of myeloma patients. Other drugs that were not available or have limited access were elotuzumab, selinexor, ixazomib, and I think it was because of the price. It was a lot because availability of other treatments for the other countries around the world. The next abstract, also we actually collaborate together with salvage therapy, multi-agent chemotherapy called ide-pace, which is Velcade, dexamethasone, adriamycin, etoposide, Cytoxan, and cisplatin. All these chemotherapies is all treatment that we have been used. Our study actually really wanted to realize exactly if there is any benefit of this type of regimen in the era of the daratumumab, CD38 monoclonal antibody, especially now it's more benign treatment, more tolerated, and more effective. And the reason we want to do that because we have a lot of patients who need bridging therapy for CAR T-cell and for clinical trials. And there was a concern about that this treatment, it might be less effective for patients who receive daratumumab and have more side effects and toxicity. So we really actually collected retrospectively 88 patients, and we found out that 60 patients were actually receiving the ide-pace after they received daratumumab, and we considered daratumumab refractory, while 28 patients were daratumumab naive, they never received it. there was different lines of therapies, like the patients group who got daratumumab naive only have 2 lines of therapy versus 6 lines of therapy who were actually daratumumab refractory. So there was a difference about that. Our concern was about the response rate. Surprisingly, the response rate in both groups was similar, about 50-53%. We look at the side effects and toxicity, and we found out the toxicity was comparable. Patients who got neutropenia and hematological toxicity were very common in both groups. It was about neutropenia 95%, grade 3 and 4. Thrombocytopenia also was over 85%, and anemia was 75%. The requirement for blood transfusion, platelet transfusion between the 2 groups was similar together. The neutropenic fever for both of the groups was also quite similar, 35 up to 45%. The rehospitalization also was quite similar. That came to conclusion that, VD-PACE have the same efficacy, however, also have the same toxicity, and it made us more comfortable about using it in case we need it for some specific situation as a bridging therapy for CAR-T or for clinical trials. Of course, we do not recommend to use it if there is other options. Mainly, we recommend to use it if the patient have a high burden disease that is acting very fast, and causing more organ damage, mainly bulky extramedullary disease or CNS myeloma or secondary plasma cell leukemia, as we believe this actually can can improve the outcomes for patients in order to get the appropriate management after this bridging therapy. The study here we talked about is real-world data about the teclistamab in relapsed refractory myeloma. As we know that teclistamab is one of bispecific treatment that targets BCMA, and it has been approved by the FDA for relapsed myeloma after 4 lines of therapy, have shown efficacy about 65%. Our group with 5 centers, the U.S. Merck with the 5 centers, have actually collaborated together to collect data in patients who received the teclistamab. And as we believe that teclistamab was very effective in these group, we actually included patients who received a step-up dose and the targeted dose. And we found out, that 80% of these patients who included in the data were not eligible to the Majestic study, which was one of the studies that led to approval of the teclistamab. The reason for that was either exposure to BCMA-directed therapy, which was common in 55%, or if they have a low poor performance status. Looking at the results, 92% of the patients were triple refractory myeloma, and 70% were penta-refractory myeloma. Around 44% of the patients were having extramedullary disease. So these patients were what we call them very complicated cases of myeloma. The results were still very impressive, like 60% of the response rate in all the groups, even in patients who receive BCMA-directed therapy, whether it's a CAR-T or belantamab in the past, they still have a response rate over 65%. And that's really what we kind of talked about that in terms of response for the teclistamab. The side effects that we notice about that, these patients have side effects like CRS, cytokine release syndrome, which was present 65%. 40% of these patients required tocilizumab. ICANS, neurological toxicity, was present in 15% of the patients. However, the major side effects that we were worried about is infection rate, hospitalization from the infection. And I think that this actually led us to believe that, although we have maybe a short follow-up for these patients, teclistamab still is available treatment and option treatment even after patients progress on BCMA-directed therapy. And we're hoping to have more mature data and more patients accrual in order to evaluate the survival benefit of this treatment as well.